Hi guys, welcome to video 3 in this Matthew Jones, Nicole McNeal review. In this video we're going to go through the exercises that I had much to do with in terms of the physiology. So in Matthew Jones we had this exercise where I asked you to draw the compliance curves for the lungs and the chest wall and use the diagram to explain what happens when you have pneumothorax. So this is vital capacity, that's nothing more than lung volume. This is airway pressure where 0 is atmospheric. At atmospheric pressure, if I take my lungs out and expose them to atmospheric pressure inside the lung, the volume that your lungs wants to be is basically 0. I mean, it's not 0 because there's tissue there. So when it collapses, the volume of the tissue is still there, but the inside of the tissue is basically almost 0. Okay. On the other hand, your chest wall wants to expand. And you see that here. So here's an increase in pressure, and as we increase pressure, the lung volume increases. But at atmospheric, it wants to be about 0. The chest wall, on the other hand, wants to expand as well, but it wants to be at a higher volume at atmospheric, much higher. So what happens in a normal individual is your chest wall and your lungs are stuck together with a pleural space in between, which is a negative pressure. Okay? And so ordinarily the volume that you see is in between the volume that the lungs want to be and the volume the chest wall wants to be. As I stand here in front of you, my lungs are trying to collapse, but they're stuck to the chest wall and they can't. At the same time, my chest wall is trying to expand, but because my lungs are stuck to it, it can't. And we end up at a volume in between here. Now, with a pneumothorax, you have air entering the pleural space. You're allowing the lung to be whatever volume it wants to be without being stuck to the chest wall. So it drops to a minimal volume, and your chest wall expands out, and it expands to a higher volume. All right? And that's what happens. Matthew Jones has lost a lot of blood because he's also got a hemothorax. Draw a concept map that explains the effects of hemorrhage, including tissue dehydration, weak pulse, pallor, diaphoresis, oliguria, altered sensorium. So, and then we're going to do a concept map. All right. So, reduced cerebral blood flow causes depressed level of awareness, altered sensorium. We have a reduced cardiac output because the filling is reduced because we've lost blood, and that causes hypotension. We have the baroreceptor reflex, which is kicked in, which has increased our heart rate, but due to the fall in blood pressure, due to the fall in cardiac output, we have oliguria. So the cardiac output is down despite the tachycardia. We have oliguria. That's because of reduced blood flow to the kidney. Remember, your sympathetic nervous system constricts and reduces blood flow to the kidney. So there are local responses in the kidney which tend to auto-regulate, but those are not going to overcome the reflex response here. And your sympathetic nervous system is still reducing blood flow to the kidney. Okay? And we have a weak pulse due to the fall in blood flow, due to the fact that we have reduced filling. We have a pallor that's reduced cutaneous flow because we've reduced blood pressure and the reflexes have kicked in and they have reflexively reduced blood flow to the skin. We have diaphoresis, profuse sweating, again due to massive sympathetic activation. The sympathetic nervous system activates the sweat glands through sympathetic cholinergic activation. Our M3 receptors cause more sweating. You learned that in the last block. All right? All right. So we can take a look at this concept map. I'm not going to take you all the way through it because I just explained all of these. The only one I want to highlight is tissue dehydration. When you get vasoconstriction, increasing resistance is like kicking a hose. The pressure upstream goes up, the pressure downstream goes down. So if you constrict the arterioles, the pressure downstream goes down. That means the hydrostatic pressure in the capillaries goes down. Because the hydrostatic pressure in the capillaries has gone down, we get reduced filtration relative to reabsorption. And as a result, our tissues dehydrate. And that's the explanation for that. Okay? In terms of our long-term reflex response, we've increased renin from the kidney, which increases angiotensin, which increases aldosterone from the adrenal gland, which increases sodium reabsorption from the kidney. We increase water reabsorption with that, and we inflate our lung volume back up toward normal. We also have a decrease in the number of impulses from our atrial volume receptors. So remember, these receptors detect both pressure, the type A, detect pressure, the type B, detect stretch in the atria, and the increased number or the decreased number of impulses that you get when the blood volume goes down causes ADH release. Okay, so we get more ADH release. That increases water reabsorption from the kidney. That helps you recover your blood volume as well, which will help reverse the decrease in circulating blood volume. Okay, so there you go. All right. So we move on to our asthma case, Nicole McNeal. You still suspect the patient has underlying asthma, so you order a methacholine challenge. So in the last video, we talked about methacholine at a low enough dose causes very little response in a normal person, but because of bronchial hyperresponsiveness, you would expect a person with asthma to have an exaggerated bronchoconstriction. And as a result of that, your FEV1 will drop and your FEV1 over FVC will drop. Note that we say here that the FVC doesn't change, probably not very much. The FVC is a little variable. You know, don't bank when you see a question stem and you see decreased or increased FVC. Don't bank on that too much. The parameter really to pay attention to is this ratio. That's what you're really looking for. And in this case, you're looking for a big drop in the FEV1. Okay, that's what you pay attention to. I think you guys know in obstructive disease, this drops. In restrictive disease, this either rises or stays the same. This is the one to look at. When you're looking at the stem of a question, characteristically, if this drops, you're looking at obstructive. If this rises or stays the same, you're looking at restrictive. The FVC, yeah, there are characteristic changes, but don't be thrown off if it doesn't do exactly what you expect. Okay, this is what you look at. Okay. And remember, the FEV1 is the amount of oxygen that you blow off when you force expiration in 1 second, and that will be reduced in asthmatic under these conditions because the asthmatic will have constricted the bronchioles and bronchi, and your resistance to flow will have increased, and you won't be able to force as much air out in 1 second. All right? And there it is. The FEV1 drops with a low dose methacholine, and that's what you're looking for here. You're looking for a drop in this with a methacholine. All right, in our flow volume curves, here's a normal flow volume curve. This is inspiration, so you increase the volume at a reasonably good rate. With inspiration initially, because you're increasing the delta P, that sort of levels off as your expansion becomes less and less, and as you inflate the airways, the resistance to flow drops, and that helps this inspiration as well, but you're not inflating as much anymore because you're reaching the maximal inflation, and so you see a leveling off of this inspiratory flow rate, and then it drops down towards 0 as you expand your chest less and less until it's completely expanded as far as it can go. And then you expire, the rate of flow increases to a maximum because you're generating a big delta P, and then the flow rate drops as dynamic compression takes place, and as your delta P drops, the dynamic compression increasing the resistance to flow. And the delta P, of course, is dropping, so you get less driving force, and so you get this decline. When you give the methacholine, you get bronchoconstriction, so the peak flow rate is less upon expiration, and then you get this characteristic scalloped appearance due to the increase in dynamic compression. All right. Note that these curves are not shifted. That's because they were meant to emphasize this change in shape and flow rate, but ordinarily you will get more air trapping in an asthmatic in any obstructive disease, and this will be shifted slightly toward higher lung volumes, okay? And in emphysema, it'll be greatly shifted toward higher lung volumes. That's because your residual volume is increased, all right? And I guess I should have pointed it out at the beginning, but do note, lung volume increases as you go right to left. That's not what you expect, but that's what you have with these curves, okay? All right, and finally we have our concept map with the response to asthma. So you have an allergic reaction, the airway radius decreases, that increases airway resistance, reduces alveolar ventilation, okay? Probably because tidal volume is dropped, so alveolar ventilation is frequency times tidal volume minus dead space. So the tidal volume has probably dropped because you can't force as much air out or inspire, and therefore you won't be able to inspire as much normally. You also have a reduced flow rate. I've had people make the case that the frequency of respiration has dropped because you can't get as many breaths in per minute. I'll accept that as well. In either case, there is a decrease in alveolar ventilation due to change in probably both those parameters. The partial pressure of alveolar oxygen drops, the partial pressure of arterial oxygen drops as a consequence. The peripheral chemoreceptor is detecting less oxygen. We increase tidal volume and breathing frequency. As a result of that, that increases minute ventilation. At the same time, our partial pressure of alveolar CO2 is increased. That increases partial pressure of CO2 in the arteries. Big A for alveolar, small a for arterial. That stimulates the chemoreceptors, and you get central chemoreceptors, and you get, again, an increased breathing frequency, an increased tidal volume, increased minute ventilation. Both are in action here. The increased minute ventilation, increased frequency, increased tidal volume means you increase alveolar ventilation, and that brings these parameters back up toward normal. So that's your reflex response to asthma. All right, that's your response to asthma. All right, good. That's all I've got. Thank you for your attention, and good luck on your formative.